I made an assumption that that arrow was pointing to the pay machine. But of course, if you were behind the arrow, that meant that you were actually out of a proper parking bay. And it's assumptions that are often a problem, I think. Now, look at Ganong's medical physiology textbook, a well-recognised, well-used textbook of physiology. I'm not expecting you to read all this, but I'll just highlight 2 sentences. At birth, the placental circulation is cut off and the peripheral resistance suddenly rises. Now, every obstetrician and midwife knows that that is not the case. That the cord continues to pulsate and have blood flowing out of the placenta and back to the baby for several minutes afterwards. And there's certainly not a sudden change. And of course, this description is what happens when the cord is clamped. But if you're taught this from as a medical student, and then it's reinforced when you're doing your training, you don't think much of just helping things along by clamping the cord. Then it goes on to say, meanwhile, because the placental circulation has been cut off, the infant becomes increasingly asphyxial. Well, of course, that is true when the cord has been clamped, but it's not true of a physiological transition. And those of us who have seen babies undergoing a physiological transition know that the baby can be fully alert, looking around, quite happy, not distressed, but not taking any obvious breaths. And then gradually it starts to breathe. 30 seconds, something like that. It will be starting to breathe. And that baby has not become, has not been asphyxiated. And Nana Weiberg's data confirms that for at least the 90 seconds that she was able to measure it. So this leads to us having 2 assumptions when we're training and learning about things. That at birth the placental circulation is cut off and the baby becomes increasingly asphyxiated. And of course Ganong isn't unusual. Virtually all the other physiology textbooks and many other textbooks have exactly the same description, either implying that there is a cord clamp or that it just, they actually maybe state that the cord is clamped, and they're talking about physiology. And in fact, Gray's Anatomy is about the closest, I think, that they can be to a proper description of a physiological transition. And then, of course, this assumption infiltrates the postgraduate textbooks. Forfar and Arneal, again, a well-respected textbook of pediatrics. You read under the heading of the normal fetal neonatal transition, the most vital change immediately after birth is for the lungs to expand to take in air. Absolutely true. Then, if lung expansion fails, death will occur quite rapidly and shortly after the umbilical cord is clamped. Now, there's the assumption, of course, that the cord has to be clamped. There's also the implication that if you don't clamp the cord, then death will not occur quite so rapidly, not quite so soon afterwards. And then look at another book. I'm not sure if it's if it's used in the rest of the world, but certainly in Britain this is a very popular textbook of obstetrics by 10 teachers. And in the chapter by Janet Rennie on neonatology, failure to respond to resuscitation. Again, you don't need to read this. She's really talking about babies who don't respond, think about blood loss and giving them uncross-matched O-negative blood. And one of the reasons that this baby might be in that state, she states, is a failure of an adequate placental transfusion due to extreme cord compression. Well, I must say, 40 years in obstetrics, I'm not sure what extreme cord compression is, but certainly cord compression, and she's absolutely right. But of course, there's an assumption there that cord clamping was necessary. There's no consideration that if the cord hadn't been clamped, then there would have been an adequate placental transfusion, because the cord compression would have been relieved and the blood returns to the baby. And this, of course, would mean the baby doesn't need an emergency transfusion of uncross matched O-negative blood, or risk a prognosis of an intact, a grim survival. And this assumption pervades other areas. Here's Helena Gardner talking about, in heart, the response of the fetal heart to changes in load, from hyperplasia to heart failure. And she says, the most dramatic changes in loading occur at birth when there's a sudden increase in distal impedance associated with removal of the placental circulation. Notice, she doesn't mention the clamp, but of course we know perfectly well that there isn't a sudden physiological removal of the placental circulation. And if that hadn't been, if the cord wasn't clamped, then presumably there would not be this dramatic load, and she wouldn't be needing to write an article worrying about how the heart's going to cope with this sudden increased load. Here's an article in Archives of Disease in Childhood, where Dawson and her colleagues are trying to define what the normal heart rate in a healthy newborn baby. And they used pulse oximetry to detect that. And she says, infants were excluded if they received any form of medical intervention. But of course, they'd completely forgotten that these babies already had a medical intervention with early cord clamping, and I did confirm that with her. And of course, this problem with defining what is the normal range pervades a whole range of other physiological normal values. Hemoglobin, hematocrit, blood pressure, blood flows through this or that organ. Nearly all of them have been done in babies that have had early cord clamping. So we have this assumption. And this leads to the idea that not interfering with the placental circulation is now an intervention. And this, of course, goes into the research projects. So delayed cord clamping becomes the intervention, and early cord clamping is the normal gold standard. Completely round the wrong way. What about this term, the placental transfusion? I mean, this is really nonsense. This is the movement of the baby's own blood from one part of its circulation to another. The blood's never been out of its circulation. It's its own blood. So it's really just a nonsense. And of course, if you think about it, a particular blood cell being transfused into the baby could well be being pumped back out again into the placenta a few moments later. There's also, of course, these assumptions that go on into or affect other definitions, like, for example, the term persistent fetal circulation, which isn't used very much maybe nowadays, but of course you can't have a fetal circulation without a placental circulation, so really it's a complete misnomer. And even what is the replacement of PHN, either standing for persistent or for primary, in the fetus, of course, there's no pulmonary hypertension. In the fetus, it's simply a high vascular resistance in the lungs. The blood pressure in the pulmonary artery is virtually identical with that in the systemic circulation. Now, I'm a sailor, and sometimes my crew or passengers are a bit apprehensive about transitioning from my yacht onto shore. And sometimes with good reason, because it is a dangerous time. But the last thing you do to help somebody get ashore is give them a push. What you do is you let them transition in their own time and be there to give them a hand if they need it. Now, there's nothing actually new, as we often discover. And I'm grateful for Jose Diaz-Rosello for this slide. From 1472, this is a book in Spanish about a medical book in Spanish about childbirth. And we see the translation is here: when a baby is born, by the grace of God, and the midwife shall have at hand a linen cloth, not harsh, but old and soft, and swaddle the infant and keep it on her lap. She will watch if the newborn infant is alive or not, and has black or white or vivid red spots, and if the infant is breathing or not. If the infant does not breathe, she shall insufflate, blow air, into his mouth. So here we have the first description of resuscitation with the intact cord, 1472. That's Paulo Gagal. So we've gone from there to 2013. There are, of course, a number of other approaches to being able to resuscitate the baby with the cord intact, but one of the ones that I've been deeply involved in is the endotherm Life Start trolley, which you'll be able to see outside, and is now readily available. I'd like to declare an interest here. Although I was a co-inventor, I, as the other intellectual property holders have done, handed over our rights to Endotherm in exchange for a donation to charity for every trolley sold. So I have no financial interest in the slightest. I have got some good news. I have a promise from Michael Weiss of the publishers and the editor of Ganong's Review of Medical Physiology, that they will replace the description of transition